Hi, everybody. Welcome. I hope I hope you can hear me. Um, Welcome to everyone who's joining our chat. Feel free to send me your questions. I'm really looking forward to this opportunity to answer some of your questions. So you can just use the chat function on the right side to just send us your questions, and I will do my very best to answer. Hopefully, everyone can hear me. It's our first time doing this, so I'm hoping it's working. I don't see any questions yet. Here we go. Okay, so how do you deal with pain and stiffness during menopause? This is a great question. Joint and muscle pain and stiffness are very, very common as we're going through the menopause transition. As estrogen is a powerful anti inflammatory in our body, a natural anti inflammatory. And so it's one of the things that as it declines, we can have more inflammation in general, which can lead to that feeling of just being stiff. I remember for me, one of my first symptoms was just feeling like when I was leaning down to put my dog's food bowl down, I would feel so much pain in my legs and hips. It was almost undoable. I was ready to just pay someone in my family to do it for me. And then when I started back on estrogen, that was one of the things that would go away. On the other hand, I struggled with frozen shoulder, and I wish estrogen had been enough to take that away, but it took a combination of physiotherapy, rest, anti-inflammatories, and everything like that to like all of the usual suspects to get under the inflammation. But another thing that's important to recognize is that estrogen is an important component of collagen formation, which is an important component of our joints and our tendons and our muscles. So when um, that's another mechanism by way by which perimenopause can affect our joints and muscles. So it's not always directly estrogen related, and estrogen can't necessarily fix it. So I do recommend, in addition to doing your regular menopause treatments, consider some physical therapy treatments like physiotherapy, osteopath assessment, massages, lots of rest, and gentle movement, but don't stop exercising. That's kind of the downfall. When you actually stop moving altogether, things tend to get worse. And that's one of the unfortunate things that can happen because it's our instinct to stop moving when we're in pain. But that's a really common question and a really great question. Does anyone have anything else? Specialists are hard to find. I want to take a little time to answer this actually because this is a really unfortunate situation that we have, especially in Ontario, where I can speak to Ontario because that's where I am. So, I am a family doctor who practices in menopause care, and I have to admit, I learned nothing about menopause care during my training as a medical student or a family doctor. Because of that, it's only by luck or fluke or desire that I went back and I certified as a menopause provider, and that was on my own time and on my own dime, and it was a time that I had to take out of my regular day-to-day career. So it makes you understand maybe why more family doctors aren't going and learning this on their own and certifying and becoming a menopause specialist. Um, and that leaves certain gynecologists to do it through the publicly funded system. Um, and there's very few of them that have the specialized training in menopause care. You would think it would be part of their routine training, but it simply isn't. So there are very select obstetrician gynecologists who offer menopause care through a hospital program. And those are OHIP covered and they are extremely long wait times right now. They're working really hard to get through the wait time, but it's still pretty excessive. So people like me cannot bill OHIP for menopause care in the community. It's very messed up, but there's no billing code. That's why you see private options popping up. Now, fortunately, there is a wide range of fee. It's like there's a sliding scale of fee options for private care, which is a really good thing because if that's your only option, at least there are different levels that you can access basically. But I would recommend to get around to your question. This is kind of a long-winded way of getting to the answer of why it's so difficult to find one. But one way that can be very effective is to go to the Menopause Society website, which is menopause.org. And they have a search engine where you can type in your city and it will come up with a list of certified menopause providers. Some of those might be pharmacists, some might be nurse practitioners, and some might be physicians. And believe it or not, all three can receive the exact same training. So that's one way to access them. Uh, yes, Sandra, me too. It's tricky. Another question. Okay, with thoughts on being prescribed the birth control, a low dose birth control pill versus HRT rather. Yes, so this is commonly offered if you're in perimenopause, especially if you're in early perimenopause, meaning you're not yet skipping periods, but maybe your periods have become erratic, you're having some hot flashes or night sweats, maybe some heavier bleeding. And especially if you need contraception, this might be the first thing offered. I will also say for family doctors, it's often what's in their toolkit that they're most comfortable prescribing. So, first thing to consider is your symptoms. Are there relatively mild hot flashes or night sweats with changes in your periods, and those are your main symptoms? Then actually a low dose birth control pill can be a phenomenal option, especially if you also desire contraception. Remember, you can get pregnant up to about a year after your final period. So it's important to take that into consideration. Having said that, it should never be like this is your only option. I have lots of patients in my practice who tried the birth control pill. Maybe it didn't help control their symptoms very well, or maybe they have more significant mood symptoms, which that can be tricky for the birth control pill to adequately control. And maybe they're not looking for contraception. Maybe that's an assumption their doctor made, but their husband or partner had a vasectomy, or maybe they're in a same sex relationship, or maybe they've had their tubes tied. There are lots of things that you could consider, which then might make traditional menopause hormone therapy more desirable. One of my favorites for perimenopause is a Mirena IUD, which also takes care of contraception with transdermal or topical estrogen. That's a really, really fantastic option for perimenopause, especially if you're having heavy bleeding, if you're having significant night sweats, you still want contraception, or even if you don't, but the bleeding's really out of control, that can be a fantastic option. And if you have a follow-up question from that, like if that rings any bells for you, or if there are any follow-up questions, feel free to, now that you know how to use the chat, um, feel free to post that as well. Any other questions? Don't be shy, everybody. This is the place to get all your burning questions out. And hopefully it's not that people are having trouble using the chat feature. It's a little tricky. I myself had to figure this out. What do you recommend for sleep during perimenopause? That's a great question. So there's sort of a ladder of sleep options. If you're on your own, if you're not yet hooked up with a menopause specialist, or your sleep issues are relatively mild and new, of course, good old fashioned sleep hygiene. Okay, we all know shouldn't be drinking caffeine, having excessive alcohol, nicotine, all of those things that can disrupt your sleep. Don't exercise within 2 hours of bedtime, although I am a terrible example because I often find myself doing that because it's my only time. But for me personally, it doesn't disrupt my sleep, but you have to feel out what's best for you. Now, if you've exhausted all of your sleep hygiene options, then you can try things. Believe it or not, there are some supplements that are extremely effective in perimenopause for sleep. Magnesium is one of them. Magnesium, there's no point really in asking for a blood level of magnesium because only about 2% of your magnesium is in your bloodstream at any one time. The rest is held in your cells and especially the cells of your muscles and bones. So, when they've done studies on the muscles of women in perimenopause, they have found there's less magnesium stored. So we know there's an overall deficiency. It just doesn't necessarily show up in the blood work. So magnesium can be a great thing to take at bedtime. I recommend bisglycinate or maliate if you have regular bowel movements. And if you tend to be constipated, magnesium citrate is fantastic because it can help with constipation. Another fantastic one, either on its own or in combination with magnesium, is melatonin. Melatonin is produced by our brain when the sun sets. And so it's in response to low light that melatonin gets released. So sometimes people try melatonin, 1, 2, 3, or 5 milligrams is usually a dose, and they find it doesn't work, but it's because they're taking it too close to the time they want to sleep. Melatonin is designed to be taken 1 to 2 hours before you want to go to sleep. It primes your brain for a restful sleep. So those two in combination, melatonin and magnesium, are amazing. If that fails, you have to divide it up. Am I having trouble falling asleep or staying asleep or both? If you're having more trouble staying asleep, like you fall asleep, no problem, you're exhausted, and then you're up 2, 3, 4, 5 in the morning, that can often be a function of true perimenopause symptoms like night sweats or hot flashes or just your brain going into high alert. Progesterone can be really helpful because it acts in the brain on the GABA receptors, which help with relaxation, calmness, and sleep. Plus or minus estrogen, because if you're having hot flashes or night sweats, that's you need some estrogen to solve that as well. But if you're having trouble falling asleep, that might be more of a job for a sleep aid. Um, Something like Dayvigo or Quvic, which are the newer generation of sleep medications, which are less habit forming and really generally safe. I'll often use those in women who really have a lot of trouble falling asleep because their brain is just wired. They can't stop worrying. They can't stop sleeping. Sorry, they can't stop thinking and they can't settle and go to sleep. Okay, so I hope that helps. Follow up question. I was also wondering about whether the benefits of HRT outweigh birth control. Thinking about ideas of bone density. Yeah. Okay. So if you don't need the birth control pill for contraception, I would go back to your doctor and be pretty clear. And depending, I don't know exactly where you are in your menopause transition or how heavy your periods are. Because if your periods are very heavy, I would actually consider either um, a progesterone only birth control pill plus maybe some body identical estrogen, which you can absolutely do, and that might help with some heavy bleeding, or an IUD, which is amazing for the bleeding, really, really takes care of it. If the bleeding is not heavy, not really a problem, and not really an issue, there's really no reason you couldn't use either cyclic hormone therapy or try continuous progesterone hormone therapy. And what I mean by that is with cyclic hormone therapy, you can take that as a woman who's still having fairly regular monthly bleeds because it can help to regulate the bleeding a little bit if you take it for 12 to 14 days of every month. And it should roughly sync up to the beginning of your period. So the first half of your cycle. And then the estrogen you would take continuously. That can really help with stabilizing your periods and giving you the best of both worlds, because I do believe we have a lot more data to support menopause hormone therapy for bone health. In fact, I've read some conflicting things about contraceptive pills and bone health. So, for the benefits that we know exist from hormone therapy, that really relates to menopause hormone therapy. I certainly don't really see a good reason for someone to be on synthetic hormones like in a birth control pill at those extremely high doses if they don't need it for contraception. Hormone therapy for menopause is much, much lower doses, body identical hormones, and very effective. I've used them countless times in women. Um, so yeah, Sandra, I hope that helps. I'm not saying necessarily that the birth control pill won't protect your bones. I don't think it's we don't look at osteoporosis in young women that are typically taking contraceptive pills. Um, and I have read studies that suggest that young women on birth control pills need to make sure they're taking vitamin D because it can actually lead to some bone thinning later in life if they're on the birth control pill for long periods of time. So I think there's conflicting evidence. And I would just maybe you'll have to lead the conversation with your family doctor, make it very clear that you don't need contraception. But I hope that helps. I think if you look into cyclic hormone therapy, that's often a really, really good option. Any other questions? Everyone's being so shy. I know we have a lot of people. Oh, okay. You're welcome, Sandra. Um, what do you recommend for hair loss during perimenopause? Oh, this is really tricky. So even though hair loss does coincide with the reduction in estrogen and with the changes that happen, so the reason we believe we that we me, I do all the research. No, the reason researchers believe that, we see hair loss and even acne crop up at perimenopause is because there is, a relative imbalance in the hormones. So what I mean by that is, okay, if we have estrogen and testosterone and they're pretty well balanced, they're pretty well balanced. So we have estrogens and androgens, so like testosterone and DHEA and things like that, and they're relatively well balanced pre-menopause. Estrogen declines, which creates a relative excess of the androgens. So it your body feels like it has too much androgen, too much testosterone, and these are like the male hormones. And so you would think by giving back estrogen, it would fix it. And sometimes it does, but I never count on it. Like, I would never prescribe estrogen to a woman if it's purely because of hair loss, because it's really 50-50 that it's going to work. And my thoughts on this are that the skin and the hair follicles are like the last priority for the estrogen that your body's getting. So if you're replacing your hormones through hormone therapy, you're talking about relatively low doses compared to your ovarian levels. And it's going to go the places it's needed the most. Your brain, your bones, your cardiovascular system. It's not hanging around like to give the little bits to your hair follicles. So unfortunately, for some women it does seem to help and for others it doesn't. There are a few options. There are some really good topical options like serums that you can get that I can put in the chat actually because they're over the counter, they're very safe. And a lovely dermatologist who's been on my podcast, Jennifer Tran, she recommends these all the time to patients for hair thinning, especially if it's as a result of hormonal changes, hormonal shifts. So those are very, very helpful. Make sure you've checked your thyroid and your iron levels, your ferritin levels. Nothing will cause you to shed hair more than low ferritin levels. And an iron supplement, you want to aim for a ferritin level between 50 and 100, which seems to promote hair growth. And then, of course, stress and sleep are crucial. We underestimate the impact that stress can have on our hair. And so I certainly recall early in the COVID pandemic, um, I I lost so much. I lost my eyebrows, my eyelashes, so much hair. It was two things going on. It was the stress of the pandemic and being like doctor during that time and all the stress of that. Um, and the same fear that everybody else in the world was having. But I also happened to go into perimenopause and had horrifically heavy, debilitating periods, and my iron was 2. So, between all of that, I lost all my hair. I took iron for a long time. I addressed the underlying, cause, the root cause. I had surgery, large fibroid, had an IUD, you name it, I've been through it with respect to the heavy bleeding. But once it was all under control, I started to notice the regrowth of my hair. So there can be multiple factors. I think I'm living proof of the fact that there can be so many different factors that are affecting your hair loss. Oh, you can say hi to Lucy, my little doggy there. She's decided to wake up and join us. Um, but it can be tricky. And then of course, if you've addressed all of that and still don't have an adequate answer or solution, I recommend seeing a dermatologist who's comfortable dealing with hair and hair loss because there are some good topical and oral medications that can really help with hair, promote hair growth. They sort of stop that um, overload of androgens and help regulate them a little bit. They block those male type hormones from getting to your hair follicles and then promote hair growth again. So, but I know it can be a really debilitating and frustrating experience. Um, Absolutely, and I hope that really helps. You're welcome. More people are joining. I wonder if anyone has a question. Hopefully, you're enjoying the answers to other people's questions, even if you're not popping. Anybody else? Oh, another a follow-up. Okay. So the question is, how do I know if I'm on the right dose of estrogen and progesterone? Um, oh gosh, I wish I could just say like, y- when. Um, so realistically, uh, um, you'll know when your symptoms are well managed to the point where you could say you have your quality of life back. I don't want to say that hormone therapy should be taking care of 100% of your concerns. There are certain things that it can do a very, very, very good job with. It can do an amazing job with vasomotor symptoms, so night sweats and hot flashes. It can do a really great job with sleep, and thereby can start to improve energy and can make a dent, certainly, with respect to brain fog. It can help with stiffness, but not necessarily localized joint pain, if that makes sense. Like if you have a joint that's very sore and inflamed, or like I mentioned, my shoulder, when I had entrapment in my shoulder and it was really, really sore, no amount of estrogen was going to really take care of that, but it did help with muscle stiffness, So I can speak from experience when it comes to that. Things like headaches, it can be really, really helpful for because those are often hormonally mediated. So I would say If you have 80 to 90% improvement in those symptoms, you're probably at your target dose. But a few caveats. If you're in perimenopause, it can be normal for your dose to need adjusting because when you're starting out, you still are producing estrogen and progesterone from your ovaries. And although they're fluctuating and they're quite chaotic, the overall trend is always going to be down. So, as that progresses, you may require higher doses of estrogen and or progesterone to counteract that. So it can be you can have a situation where you feel like you're cruising along and you're feeling great, and then suddenly you're not feeling so great, and that's where you want to go back and revisit it. Um, and then certain things you have to really have a realistic understanding of the fact that they're not the symptoms that are necessarily going to respond as well to hormones. The big one that comes up over and over, well, there's a few. Um, Brain fog, even though you can start to see some improvement, the other thing that's required to improve brain fog is simply time. Your brain is going some organizational and structural changes in the menopause transition. And so you have to allow that to happen and you have to allow all of that to fall into place. Your brain is going through the opposite of puberty and it's creating new connections that are going to serve you well in your post reproductive life. So that kind of gets you halfway there with hormone therapy, and the rest is just time. The other big one is weight gain. Women are often super frustrated because they start on hormone therapy and they are expecting it to cause them to lose weight. I will say weight gain is really complex and multifactorial. Yes, the sex hormones play a role in it, but so do your gastric hormones. So the hormones that drive hunger and fullness. Um, our microbiome changes. So our ability to use our nutrition from our food declines. Our ability to metabolize fatty acids and carbohydrates declines. And then on top of it, sleep. Poor sleep is an independent risk factor for weight gain. Night sweats and hot flashes are actually an independent risk factor for weight gain and waist circumference. Um, and genetics, right? The great genetics, which we have zero control over. And then habits, right? Like what are we eating? How much are we drinking? All of those things can contribute. How much are we moving? Um, what's happening with our muscle mass, of course. We're losing muscle mass from the time that we are about 35. It's in a steady decline. So, strength training and resistance training, the reason I harp on it so often is because it's crucially important for women, especially because we are noticing a steeper decline in our muscle mass and our bone density because of the loss of estrogen. So, all that to say, weight gain is not something I expect to see dramatically improve on hormone therapy, although I set expectations with my patients that I would like them to notice around the 3 to 6 month mark that they feel they've regained some control, that they're like, oh, I felt like it was just totally out of control. Like anything I did wasn't working. Now I sort of have back that semblance that the things I'm doing are actually helping. Wish they'd help faster, but they're helping. Like, for example, you're not having hot flashes anymore. You're sleeping. You're getting that 7 to 8 hours of really good quality sleep. That means your stress levels are coming down a little bit. And you're able to fight cravings. Maybe you don't need as much wine at dinner because you're just feeling better and more relaxed and calm. So you see how it's an indirect benefit of hormone therapy on weight, but it's not a direct benefit. So you can never judge your dose based on that. I hope that makes sense. There's a lot of information in that answer, um, but it's a complex one. It's a complex question. And so I wanted to give it the complexity of the answer that it warrants, because this is the kind of question I get all the time, and I wish it was as simple as, let's give you some estrogen and you'll lose some weight. Any other questions? That's a good question. How long does it take HRT to work? And the good news here is it can work relatively quickly, especially for those quick hit, those more certain, I guess, symptoms that we talked about before. So when it comes to hot flashes, night sweats, and sleep, I often tell women that they may have benefit their first night. Believe it or not, it can be that quick. I have had many, many patients tell me the first night that they were on HRT, they had the best sleep that they had in years. They felt so much better. Their hot flashes never happened again. That's how amazing it is. And a funny story about that, actually. So the Women's Health Initiative, which was the big study that was done 20 years ago, that I think it's a good study because actually, if you look at the data, it just showed how safe and effective hormone therapy is. Um, but at the time, of course, we all know there was this disastrous press conference. They came out and they just took this tiny microscopic potential risk of breast cancer and they blew it up so that that's all anybody heard, and then everyone was terrified and stopped using their HRT. Well, one little known fact about that study is they preferentially looked for women to participate in the study who didn't have any symptoms. They did not want women who had hot flashes. And the reason was it was a blinded study, meaning some women were given hormones and some were given a placebo, and they didn't want the women to know if they were getting placebo or hormone. And they knew that women would know right away if they were on the hormone. So in order to try to blind the study as much as they could, they actually chose as many asymptomatic women as they could, which didn't do much for the data, but they weren't really doing the study to see how well it worked on hot flashes. They already knew how well it worked on hot flashes. They were doing it to see if it prevented cardiovascular disease. That was the main objective. So it's kind of funny. That's how effective hormone therapy is, because you'd know right away if you're on it. Things that take a little longer are the things we talked about, like brain fog, fatigue, um, weight stabilization. Those are on the longer range. Those are 3 to 6 months or more to stabilize. But the really quick things are hot flashes and sleep. So it's a great question. And sometimes, you might think it's not working. You got to give it 4 to 6 weeks to get the full effect of a particular dose. After 4 to 6 weeks, if you're not feeling a lot of benefit, you should talk to your doctor about increasing your dose, because don't give up. Sometimes people um, think it's not working and they do give up, but that's often when they're not given the option of a follow up appointment and they don't understand that you often have to increase the dose to get to your optimal one. I hope that I hope that answered your question, was helpful. Anyone else? So how do I know which HRT is best without having to try a whole bunch of different ones? Um, I mean, that's really my job the way I see it. I what I typically do is I listen to a woman's story, I analyze her health history, her her target symptoms, her desire for contraception, her preferences in terms of, maybe I think she's a perfect candidate for a Mirena, but she would not choose a Mirena for anything. There's just no convincing her to have a Mirena, right? So I typically do some matchmaking because there it is a bit of an art to it. So, if you're trying to kind of do this yourself because you're like, "Listen, I gotta go talk to my family doctor, and I know they don't know." Or so I've even heard women go to their family doctor, and the family doctor says, "I don't know, go do some research and come back and tell me what you want." I mean, that's actually not a bad scenario because at least the family doctor is willing to prescribe it. So, great, that's fantastic. That's how I started with women just saying, "I want this." And I'd be like, "Ooh, okay." Um, so knowing what types are available. And that's why in the course that we've put out, I take an entire week basically explaining all of the different options, hormonal, non-hormonal, etc., so that you can sort of start to see. You have to know, okay, what is my cardiovascular history? Am I low risk for cardiovascular disease? Okay, and basically, if you have nice normal blood pressure, if you've never been given a medication for your cholesterol, you know you have normal cholesterol. Um, if you do not have diabetes or kidney disease, if you're not a smoker, if you're um, don't have a parent who died very early of heart disease, these are all things that can affect your own individual risk. So that might dictate because somebody who's higher risk for cardiovascular disease would probably want to avoid oral HRT, oral estrogen. You might want to trend towards topical estrogen, so a gel or a patch. Um, if you, like I said, need contraception, you want to think about an oral contraceptive pill versus a progesterone only pill versus a Mirena with estrogen. And if you have, if you're high risk for breast cancer or you have very, very dense breasts, um, you may want to consider something like Duaviv, which avoids the breast tissue altogether. And although we definitely need more studies to confirm once and for all that it's extremely safe for women at high risk for breast cancer, we have a pretty good idea that it is. In fact, it's being tested in that capacity right now. And by the way, family history of breast cancer or high risk for breast cancer without being diagnosed with breast cancer is not a contraindication for being on hormone therapy. The only concern is that sometimes hormone therapy, especially the progesterone, can increase breast density a little bit. And when something increases your breast density a little bit, it can just make mammograms a little bit less um, effective, and it can make it more difficult to see masses that might be in the mammogram. And I think it's a good time to maybe springboard off of that and say that the guidelines are dramatically changing with respect to mammograms and breast density. And some family doctors have been a little slower to pick up on this. So the good news is when you get your mammogram now, which every woman 40 and up can self refer in Ontario for a mammogram. So if you haven't done it yet, please go do it. But you now get a letter back that tells you your breast density. So it will not only say your mammogram showed no signs of cancer, but it will say your breast density is category A, B, C, or D. Now, A and B mean you do not have dense breasts, means your breasts are almost entirely fatty tissue. That means your mammogram was more accurate because it was able to compress and see through the tissue very effectively. If you have category C density, this means you will be at 1.5 times the average risk for breast cancer in your lifetime. This means you have dense breasts and you should be going for an annual mammogram. No matter what that letter says, you go back in a year and you do another mammogram and a breast ultrasound. Breast ultrasound should be done, and you should ask your family doctor to refer you back for an ultrasound if you have category C or D density. Now, D is the densest. If you have category D density, that means you are double the lifetime average risk of breast cancer. So understanding what that means is really crucial. And eventually, I think the message will get out that you should be having annual mammogram and a breast ultrasound. But I just know for a fact we're not there yet, because when I see women for an initial consultation, and I always want to see their baseline mammogram, same as I want to see their bone density and I want to see their recent pap test, because women's care is women's care. W- what good is it to help someone with their hormones and help them with their symptoms if they have a cervical cancer lurking that nobody's picked up on? So I take it as an opportunity to really holistically look at their entire health picture and point them in the right direction. So I will often see women who had their mammogram, saw the letter, were told it was category C, family doctor didn't send them for an ultrasound. Maybe they're not aware yet. I mean, these are all pretty recent changes and revelations, and it's not like formally in the guidelines yet. It should be, but it's not yet. So that's changing. The task force that was responsible for the mammogram guidelines has really been called out lately. Thank you to the amazing women and doctors and surgeons who are out there sounding the alarm that our guidelines were so misguided and outdated, and they are changing it. And that's what led in part to mammography now being recommended at age 40. Thank God, but we still have a long way to go. And this is where women need to just keep advocating for themselves. You're not incorrect to go back and say, I have very dense breasts. I understand that, I should go every year and I should have an ultrasound of my breasts to make sure that small nodules are not lurking there that couldn't be identified on the mammogram. Just so you have an idea, breast ultrasound can find an extra maybe 6 per thousand breast cancers that were not discovered by mammogram. I've seen this happen myself in practice where mammogram was perfectly normal. Ultrasound found a suspicious nodule, and that turned out to be cancer. So it does save lives. Um, and yeah, so that's very, very, very off topic, but these are just like examples of some of the things you'd want to consider when thinking about HRT. And for my own practice, I often present a woman with several options that are available to her. Um, because it's not like this is what it shouldn't be. This is what you're getting. Unless they have specific risk factors where I'm like, listen, we can really only consider something. For example, if they have a history of a blood clot, you don't want to be on oral estrogen. You would only want to consider topical estrogen at lower doses, which is great because we have that as a beautiful option. But that's an example of where I'd be like, we're a little more limited in our options, but you still do have options, gel versus patch versus, um, I don't know, versus just progesterone. There's lots of things to think about. Anyway, did I any other questions there? Making sure I didn't miss anything. So how long can I be on HRT? Is there a limit? How do I know when I can stop? This is a great question because I get asked this all the time, and probably the answer I would have given even 5 years ago is quite different than now because they've recently updated the guidelines again. So, uh, the Women's Health Initiative, because they identified a slightly higher risk of cardiovascular events and breast cancer in women who were over 60, they put together guidelines with that in mind that said, well, Obviously, then we don't want anyone to stay on hormone therapy past age 60 because then they're going to be at these higher risks. They sort of thought the risk came from being older, but now we understand if you've started hormone therapy at the right time. And what I mean by that is there's something called the window of opportunity, which is before age 60 or within 10 years of your final period. So if you're in perimenopause, it doesn't really apply to you. But for someone menopausal starting hormone therapy, you don't want to be more than 10 years from your last period. Um, Once you're out of that zone, the benefits are less likely to apply to you and the risks go up a little bit. Having said that, we now realize if you start in the window of opportunity, you actually benefit from continuing hormone therapy for as long as you wish to. There may be things that arise in the future in terms of your health that would necessitate stopping your hormone therapy, either temporarily or permanently. Some examples would be a heart attack or stroke. If you have a heart attack or stroke, they would likely tell you stop your hormone therapy, at least temporarily while that's managed effectively. If you develop breast cancer, and even though we have a lot of evidence to suggest that hormone therapy does not cause breast cancer, a lot of the treatments for breast cancer involve blocking hormones. So, because of that, it would be a contraindication to be on your hormone therapy if you have hormone positive breast cancer. Although, if you have hormone negative breast cancer, you can actually continue your HRT through your treatment. I have a patient right now who's doing that. And then uh, uterine cancer. Uterine cancer is fed by estrogen. So you could continue your progesterone. And in fact, progesterone is often part of the treatment protocol for uterine cancer. You cannot be on estrogen if you have a uterine cancer. You may be able to go back on it after they've treated the cancer, but that would depend on how aggressive it is and the type and whether you have a hysterectomy. That's really complex for this kind of a discussion. But the bottom line is hormone therapy can be continued for as long as you wish to because you will continue to reap the benefits, particularly to your bone and for your arteries if you continue on it. We have so much data that women live longer and healthier lives when they remain on their hormone therapy beyond age 65. So, great question. And you can stop if you want to stop, but bear in mind that if you stop, you have to then think about your bones a little more carefully because you've been on something that's been protecting your bones for all that time. And I have seen recommendations where it's like if you've been on hormone therapy for, say, 5, 10, 15, 20 years, and then you come off it, you have to really watch your bones carefully and consider going on a medication for bone density to prevent yourself from going into a bone density decline. Do we have any more questions for tonight? You're so welcome. I think if that's all the questions, I think we can officially sign off from our first live. And I want to thank everybody for joining us. I know people were shy, not necessarily wanting to share their own questions, but everyone who did, thank you so much. I really appreciate it. And don't forget to follow Medsplaining on YouTube, on TikTok, on Instagram. Don't forget to listen to the podcast on your favorite podcast platform. We have tons of information and Q&As and myth busting for HRT, and lots of great general health information and skin and hair information too. So appreciate everybody being here tonight, and you're all so welcome. Thank you for joining, and I look forward to seeing you at the next one. Have a great night.